Now we'll be moving on to the next session, which is infections of liver disease, for which I invite the chairpersons for the session, Dr. Kin Mohan Bin, Dr. Neelam Taneja, Dr. Nusrat Shafiq. I kindly invite the chairpersons to the dais and invite the speakers for the talk. Thank you. Dr. Neelam Taneja was not able to join us because of some emergency situation. Thank you.
Do we have Dr. Kim here? Could anyone confirm if we have Dr. Kim here? So if not, I think we can proceed with the session, because I can see that there are quite interesting topics here and with very eloquent speakers there too, experienced ones as well. So may I invite Dr. Anita Verma to open the session with her talk on treatment of multi-drug resistant organisms in cirrhosis and challenges in the management.
So first of all, I'd like to thank the organizing committee for inviting me, and it is privileged to be here today. So I will be sharing the experience, some of how we manage the multi-organ resistant organism, and what are the challenges in the management. So first of all, we need, sorry, so we know that infections with MDR is a growing concern worldwide, and their management requires a multifaceted approach that include the treatment strategies, antimicrobial stewardship, and infection control practices. So cirrhosis, the underlying diagnosis itself, is a very high risk factor for bacterial infection. If we see the infection rate that varies according to the severity of the liver disease, it is very highest in the decompensated stage and acute on chronic liver failure, and 50% infections are community acquired, and the most common is spontaneous bacterial peritonitis, and 70% are the nosocomial. So most common infections are due to coliforms, that is up to 40%, and the most common gram-positive is enterococci in the liver patient, and up to 40 to 60% are the culture positive only. So there is an increasing incidence with the MDROs. So what is a multi-drug resistant? Multi-drug resistant is a resistance to all antibiotic in at least two of the three following classes: beta-lactams, aminoglycoside, and fluoroquinolines. So pan-resistance is when they become resistant to all licensed antimicrobial which are used clinically. So an incidence of a CRO MDRO differs considerably among geographical areas, that is up to 10 to 70%. So risk factors are recurrent hospitalization, frequent use of invasive manures, and recurrence of antibiotic therapy for prophylaxis and treatment. So this is just slide to show the geographical variation. There's very high rate of multi-drug resistant organism in the Europe as well as in the South Asian Pacific region. So if you look what are the key multi-drug resistant organism, among gram-positive, they are the MRSA, and VRE, they are the highly prevalent. And among gram-negative, these are the extended spectrum beta-lactamases and CRE, which I will talk. What are the CREs a bit later. So what are the impact of these MDR? They're associated with very, very high mortality, particularly the CRE. There is a 5 to 10 times the higher mortality, and they contribute a longer length of hospital stay and higher medical cost, and failure of empirical antibiotic therapy. So this is the INASL guidelines, which recommend the narrow spectrum beta-lactamase for the treatment of cirrhosis in patients. They are good for treating the community-acquired infection, but they are not good for treating the when it comes to MDRO infection. So they are infective in nosocomial and health-acquired infection. So this is the just INASL study from including more than 1,300 patients from 46 centers, and the global incidence is 34%, which is quite high. And if you look at the implication of on the MDRO bacteria, there is a lower rate of response to empirical antibiotic therapy. Very high patient goes into multi-organ failure and low resolution of infection and higher in hospital mortality. So that's the implication of the narrow spectrum therapy. So there are few articles which shows that broad spectrum antimicrobial is better. They reduce the mortality, and this is one of the study where they have used the imipenem or carbapenem combination compared to third generation cephalosporin. It is significantly have reduced the mortality and reduce the rate of treatment failure and also reduce the length of stay. And this is another study which shows that there's a significant reduction in mortality in patients with Cliff SOFA score more than 7 when used the carbapenem comparison to third generation cephalosporin. So this is a survey from low middle income countries and what is high income countries, which shows what are the antibiotic impact and what they are using. So this survey shows that most centers in the low middle income country, they follow international guidelines. So for example, they are INASL guideline, ITSA guideline, they are following that. They are not following their local guidelines. And whereas the high income countries, the more centers are following local guidelines and national guidelines. So in summary, that empirical antimicrobial therapy guide is that it has to be your local guide, and it has to be based on the some of the empirical antibiotic therapy, which should be tailored based on the severity of cirrhosis and whether it is community acquired or local your epidemiology, local resistance pattern, and risk factors for CRO. Initial treatment with broad spectrum antimicrobial is good in the patient with sepsis and cirrhosis. And we use piperacillin tazobactam as a single therapy plus minus glycopeptide if there is a MRSA colonization. And if there's a high incidence of CRA, then it's always carbapenem based combination is better. So what are the targeted treatment against MDRO? So understanding the resistance mechanism lead to better treatment option. Bacteria are versatile and very adaptive. They can acquire resistance for any antibiotic when you use them. So there's a natural resistance, for example, which is intrinsic resistance, which is always expressed in the bacteria for the first and second generation of cephalosporin for Pseudomonas. And acquired resistance, it is acquired by the different mechanism. The most common are the alteration of the target site and alteration of the cell permeability and production of the enzyme. And that is the most common mechanism in the current era. So beta-lactamases are the major mechanism of bacterial resistance. And if you look the extended spectrum beta-lactamases, now there are more than 300 enzymes. With the genes, resistant gene keep on adding to the list. And these resistant genes, the most common, which is now prevalent is CTXM, and that is contributing to the more CREs. And the MC, they are chromosomal induced, and they are very common in the like Enterobacter, Acinetobacter, and Acinetophomonas, etc. So carbapenemases are the enzyme which break down the carbapenem. So in the current era, carbapenemases are the worst versatile beta-lactamases, the most versatile. Why? Because they are coded in a mobile gene, which is called plasmid, and particularly they are mobile gene, and most of the coliforms, they are present in that, which are the most common gut flora in everybody's and in every human being. And not even that, because they are mobile, so they move from one bacteria to another. Like Pseudomonas, they are moving to. You can find them in Acinetobacter. The most important thing about them to learn is that they are spreading rapidly. They are spreading when one patient is positive in the ward, many patients can get positive. They spread in the from patient to patient, to the staff, and to the environment. That is one of the reasons that there is a widespread of these bacteria. So it's very important for you to know these big five carbaphenamases because they are globally present and they're limited therapeutic option like KPC, OXA, and IM, NDM, and WIM. So this is the Embler classification where I would like to particularly highlight the metallo-beta-lactamases, NDMs, because they're limited option. We don't have many treatment for these bacteria. This is our KCH King's College data. So we do screening of these CPCRE, weekly screening, and so that we know that whether they are colonized with that or not. So what will be happening is that we have significant reduction of CPE, but there is a increase over the year of non-CPE CRE. So that is because of selection pressure of antimicrobial. More you use antibiotic, the more you will get CRE resistance. So VRE is very highly prevalent in cirrhotic patient, and their rate stays a constant. But they are not very pathogenic. MRSA is also less pathogenic in cirrhotic patients. So this is one of the patient I dealt with. I like to highlight that one. That there's a 57-year-old patient with primary biliary cirrhosis awaiting for the liver transplant. She presented with lethargy and confusion. Day one, she was admitted to ICU. She was started on empirical treatment, which is our first line treatment, is tazocine and amikacin. And developed day two, she developed multi-organ failure. And we did a diagnostic paracentesis. She was diagnosed at spontaneous bacterial peritonitis. And day three, we changed to more broad spectrum antimicrobial. Based on that, patient was very septic. And this is on day three, we got the sensitivity pattern. Turns out to be meropenem resistance. And now we do know that what we do when there's a meropenem resistance. Day four, we started with a more broad spectrum beta-lactamase inhibitor combination, and the VRE is also present, so we added the daptomycin. So you can see day 7, we are able to get the full sensitivity pattern that is for beta-lactamase inhibitor. But you need to understand that these are not present everywhere. You can't see the sensitivity pattern immediately. So what is the challenges here? There's a delay in the right choice of empirical antibiotic, delay in the right diagnosis to diagnose whether this is CP or non-CPE, and delay in the treatment by 72 hours. And all these factors are associated with very high mortality. So coming to that, just with more specific with the targeted treatment. So MRSA, it is highly colonized, but there is a less infection. There is a treatment option there, and we can decolonize it. That reduces the infection rate. Whereas VRE is very high rate of colonizing liver patient, up to 40 or 50% in our center are colonized. And associated with high mortality, it is indirect indicator of the underlying comorbidity or condition of the patient rather than it is not very pathogenic organism. There's a limited treatment option. We can only treat with like linezolid or daptomycin. That's are the only two treatment. And we can't decolonize these organisms from the body. So the main gram-negative are the ESBLs. The first line treatment, every guideline indicate the meropenem. So this is the reason that we are getting more non-CPE CRA, because ESBL is highly prevalent in the population, whether it's a normal population or patient with cirrhosis. The second line is again BLIs. The treatment of CRE. CRE is the WHO priority pathogen, and so we need to understand whether the most important thing is, do we know that it is carbapenemase producer or it is non-carbapenemase producer? You need to know these big fives. So based on that, you treat these patients. And also you need to know that CRE, when we call carbapenem resistance, they 50% could be sensitive to carbapenem. When they are sensitive, you need to know MICs, and based on that, you choose to treat with meropenem because there's better outcome with meropenem. So if the MIC is less than 4, we use extended meropenem infusion. If there is a MIC between 8 to 16, you use combination therapy with meropenem. And we can use tigecycline and evracycline as well. So this is the IRSA guideline, particularly targeting the 3 enzymes, KPC, NDM, and OXA. So they all recommend combination of beta-lactamase inhibitor or single therapy. So NDM particularly, you need combination treatment. You can choose to do single therapy or BLBLI with KPC or OXA48. The problem is, are they available everywhere? These BLBLI, they are the drawback of or limitation of these BLBLI is their poor availability. They're very very costly. The per dose per day cost is like $1,000 to $3,000 per day. They're less effective against metallo-beta-lactamases. And not even that, more we are using them, we are getting resistance to them. They are 10 to 20% resistant to ceftazidime, avibactam, which is at the moment easily available. So this is the chart showing that the red part is the one which we can't cover. And in low income country, we are using the colistin more, and there's limitation of colistin. And no matter how many antibiotics you are going to introduce, sooner or later they are going to become resistant. So are there any non-antibiotic approaches? Some of them are like fecal microbiota or prebiotics you can use. There is a limitation with these therapies as well. Now, take home message is that MDRO infection is very common, and treatment is no one size fits all, and therapy should be individualized and improve diagnostic. That's the most important thing. And antimicrobial stewardship is very important. You should take 2 steps: de-escalation and short duration of an antimicrobial. That can reduce the resistance. And surveillance, screening of CPE reduces the help in targeting the therapy and prevent spread, which is most important. You need to have robust infection control practices. And thank you.
Thank you, Dr. Anita. Thank you for elegantly covering all the key aspects of the topic. And I think that's reflective of the important position you hold as consultant and honorary reader infection sciences at King's College Hospital. I'm quite sure there would be a lot of questions at the end, but I think we can take them all at the end. So may I just request you to kindly join for the discussion at the end. Then we move on to our next speaker, who is my colleague in the hospital, and Dr. Nipun Verma is going to talk about a very interesting topic about novel biomarkers and protein signatures in infections, infection-related acute decompensation of cirrhosis, as a tool of precision medicine. So over to you, Dr. Nipun.
Thank you very much, ma'am, for the kind introduction. And I wish to thank all the audience just before the lunch. They are here. I want to thank all of you. So my job is very easy after Dr. Anita's talk, that infections leads to poor outcomes, and we need to identify these patients early on. And how do we do that? Using cultures and biomarkers, and perhaps the hybrid approach of genomics is the way forward. So I have no disclosures. So let me start with basics. So we all understand, we have students here, that infections is something when pathogen breaches the barriers and leads to local inflammation, which is altered, and it leads to signs and symptoms of infection. And when this becomes perturbed through a systemic dysregulation in immune system, it leads to sepsis. This sepsis is operationalized with the definition of organ dysfunctions and organ failures. We call it 2 points rise in SOFA scores, and that leads to multi-organ failures in unchecked phenomena and leads to death. Now, how does this perturbs in patients with cirrhosis is a real question. Because per se in cirrhosis, an acute trigger such as alcoholic hepatitis, drug-induced liver injury, per se leads to liver inflammation, which also become derailed and leads to systemic inflammation because of sterile immune dysregulation, and organ failures per se because of sterile inflammation. So there is a complete overlap of definitions of sepsis and organ failures occurring per se because of sterile inflammation. And then there can be a trigger per se because of infection. And in this chaos, how do we find out whether a person is truly an infection? And even if we say that a person is infected, whether we need to treat them with antimicrobials? And perhaps the answer is no. We need to do less to be more effective. So let me take you through the effect of infections on the outcomes of patients. And we all know this is a landmark study, predict study, which showed whether the patient is acutely decompensated or presenting as organ failures, adequate antimicrobials improves outcome. What does adequate antimicrobials mean? It means not only the right choice but also the right time, because a patient who's presenting to us with shock, any hour delay is going to lead to 1.8 times higher odds of mortality. And this is important because in patients with cirrhosis who are presenting to public sector hospitals coming from different other institutes, they are inappropriately or inadequately treated. Now, whether systemic inflammation per se can be used as a predictor for infection, the answer is well, yes. This is an interesting study from Dr. Serene's group showing that SIRS at presentation and follow-up can actually predict who are the patients likely to progress to infection, and patients with SIRS had higher mortality. However, if we see, this is the largest study from India on infections led by Pratibha, who is a PhD student, who actually found that about proven cases, if we take 100 proven cases, about 40% of them will not have systemic inflammation. So this is an immune dysregulation where the systemic inflammation is not present. Whereas on the contrary, non-infected patients will have SIRS as a sterile inflammatory state. But we need to understand that this data is proven infections and no infections. What about intermediary patients who do not fulfill the proven infection criteria, that is, who are suspected to have infection, which are about 30%, and those who fulfill the clinical criteria for infection but do not have the microbiological cultures? So this remains an open area. And here in this study, we understood that patients with SIRS, it is the presence of infection which led to the poor outcomes, not the presence of SIRS. Now we have NACSL criteria to define infections, and it is clear cut, but I must admit, looking at prospective data, about 30% of individuals will not fulfill a select criteria given in INASL or NACSL. And therefore, there is an unmet need to identify patients early on for ruling in infections, but also for ruling out infections so as to prevent overuse of antimicrobials, because multi-drug resistance is coming up in a big way and we have to be really cautious about using antimicrobials. There are a lot of confounding factors for systemic inflammation listed here, and we all know as a clinicians, lot of like hepatic encephalopathy, tense ascites, hepatic inflammation, the sterile inflammation, it all perturbs our SIRS criteria. And infection, as I mentioned, the microbiological cultures are also not adequate. Either we are not sending it properly, the system is not available, as a recent study from Dr. Jasmohan Bajaj's group in Lancet showed. Most of the lower middle income countries or lower income countries don't even have the microbiological systems to diagnose infection. So what to talk about biomarkers? So we have to really look at the ground level, where are we working and how we can improvise through point of care diagnostics to come with certain biomarkers to improve our infection diagnostics and target our antimicrobials in appropriate way. Now, if you look at the literature, there are several of protein-related biomarkers ranging from procal, CRP. We all know that, right? Whatever said and done, we hardly rely on most of these biomarkers as to guiding what type of antimicrobials we have to give, because clinically when we suspect infection, it is our empiric choice of antimicrobials based on the existing epidemiology and the MDR colonization, as Dr. Anita has mentioned. Procalcitonin is generally implemented as a tool for negative predictive value and ruling out infections, but I must admit it does not work well in patients who have UTI or who have pulmonary infections. And the guidelines also do not support the use of procalcitonin for ruling in infections. However, there is a clinical chemistry guidelines which do say that the kinetics of procalcitonin, that is 50% decline over initial few days, can be looked at as a predictor of resolution of infection. Now, there are other biomarkers for fungal infections such as beta D and galactomannan, and which I would like to say that has a preliminary study about 100 plus patients, 219 patients from PGI. We showed that the beta D glucan is very sensitive for ruling in infections, not for ruling in, for ruling out infections, fungal infections, and galactomannan very specific for ruling in the pulmonary aspergillosis. Can we do something better? So this was the work. Again, Pratibha is a PhD student who helped us in conducting this study, and Dr. Jasmohan Bajaj, who's guided us at the end, fag end of this study, that how should we represent the data and how to best present that. So this was a study where we took patients with proven and infections and no infections, did plasma proteomics to find out the protein signatures specific to infections, and then we tried to validate in 3 different cohorts, 2 from PGI and 1 from PGI Rohtak, and Dr. Tarana helped us in that, where we identified that a biomarker panel, including galectin-3 binding protein, which is an interesting protein, I'll come to it, combining this galectin-3 protein with procalcitonin and clinical scores such as CLIF-OF and lactate, we could improve our diagnostics for ruling in as well as ruling out infections. And the overall performance was 96% in the cohort 1, ranging to 90 and 95% in cohort 2 and 3, and which actually led us develop a biomarker panel for this infections in cirrhosis. There are other pathways which were perturbed, and we'll come to it. Now, coming to the specifics about this study, the 3 proteins which were very important for ruling in infections were galectin-3 binding protein, which is nothing but a pathogen acute phase reactant which actually binds to the pathogen molecules and tries to prevent the overactivation of immune system, and it is a protective phenomena. Whereas PLTP is something which binds to lipoproteins and tries to instigate the systemic inflammation through the monocyte activation and subsequently the T cell activation. The third protein which was very, very important was the glutathione peroxidase 3, which is a marker of ferroptosis or oxidative cell death. These forms combined together was accurate to the tune of 85%. However, due to lack of logistics, we could only validate the galectin-3 binding protein in this study, and when we combined with, as I said, clinical markers, performed really well in ruling in infections in patients with cirrhosis. We came up with this calculator, and on decision curve analysis, we could show that treating all versus none, the patients, if treated using this biomarker based approach, would have actually net benefit in treating the patients, whereas it can also reduce the antimicrobials use by inappropriately ruling in, or once we are using it, we will not be able to include patients with infections which are actually truly no infections. The subgroups, we could see that the performance was consistent in AD, ACLF, surviving, non-surviving patients, and even the probable group of patients where I was mentioning that about 30-35% of individuals do not fulfill this the proven infection criteria. So there also the performance was 95% accurate. Now I was mentioning about the different pathways, because it is just not the antimicrobials which is likely to improve the patient's outcome. It is the biology which, apart from pathogen triggering the immune system, the biology which is driving the patient outcome needs to be tackled. And obviously, I think the way forward, which Dr. Bajaj is going to speak, is the non-antimicrobial therapies. So let me just tell you briefly that when we compared patients who did not have SIRS compared to patients who develop SIRS, there is a complete shift of immunometabolism, and there is a more and more utilization of fatty acids, the proteins related to fatty acid utilization in immune cells. And then there were markers related to phagocyte dysfunction, increased gut permeability. Whereas once a person traverses from systemic inflammation to infection, there is an immuno-exhaustive response to infections. And there, the phagocytic capacity and the proteins related to phagocytosis really go down. And therefore, the implications of such findings include that if we target pathogen in addition to host biology, we are likely to improve the patient's outcome. Now, coming to the other biomarkers which are emerging in this arena is the metabolomics, and this is a study from EF Cliff Consortium by Dr. Maru, showing that the metabolites related to mitochondrial dysfunction were highly discriminative of infections in ACLF. Now, there is an interesting study presented during INASL this year, where they showed patients with acute and chronic liver failure, whether they were incited or triggered through alcoholic hepatitis or infection, the two biomarkers came up significant, that is the IL-6 and the eotaxin, and these markers could differentiate that whether a person has an infection or no infection in patients with ACLF. Now, as I was mentioning on hall 1 in the early in the morning, that cell death is very important. Cell death markers can also differentiate infection and non-infection in ACLF, and RIPK3 is one of the markers which has shown to be classically different in patients with and without infection. Now, there is another marker which has recently published, which in Journal of Hepatology, showing in dysregulated immune response, and this dysregulated immune response through pyroptosis, which I was again mentioning early in the morning, that the pyroptosis, once activated, releases certain molecules from the cells, such as progranulin, which was correlated with a higher detection rate of infections in patients with cirrhosis. Now, there are a host of several other biomarkers of immune activation, such as neutrophil CD64 expression. Dr. Pandey's work from SGPGI, an accuracy of 95%. However, further studies are not there to validate these findings. Now, there is an emerging role of stool microbiome. Dr. Bajaj is going to tell us more about the microbiome guided therapies. So, the panel of stool microbiome differentiating infections and non-infections in AD and ACLF was beautifully described in 2014. And then there are markers related to calprotectin and presepsin, which is far from reality. So what we see today is that biomarkers are able to guide but not to select our antimicrobials. Therefore, there is an unmet need for improving our diagnostics, the microbiological diagnostics. A lot of work is going on in the sepsis arena. Not only the early diagnostic systems such as MALDI-TOF, the T2 system for Candida, the enhancements through next generation sequencing and targeted PCR. So this is the two studies which I would like to share, is that next generation sequencing is you take out the DNA from blood and sequence it and map it to the bacterial genome and try to find out what is the type of bacteria in that or fungus in that sample. So it can be done directly on the samples. If you see in this study, they showed that patients who had sterile ascites, when reclassified through NGS, about 60% individuals were found to have bacteria. Then there is a rapid improvement in the targeted PCR panels, and we all know BioFire is there, but it works on only the microbiologically proven infections, and these targets can only be employed if the culture is positive. And if the culture systems are not available, what to talk about BioFire? Whether these can improve our the decision making, the answer is again yes. The NGS based treatment recommendations was employed in this study to improve the antimicrobial decision making, and they showed that about 55% of individuals in this study were able to, there was a positive effect on the diagnostics, on the treatment change, which led to the improvement in outcomes. So takeaways from my presentation is that without precision testing or educated guess, we are not able to find a right antimicrobials at a right time in a given individual. And obviously most of the problem arises with the system of a given healthcare. And with precision testing, which we are moving towards, is more of an informed therapy where NGS or PCR based panels would increase our pathogen detection rate, and no guesswork would be there in future. Whereas the protein markers, which I see is an important biomarker based approach for ruling in and ruling out infections, and Pacify is one of the models which we can use for ruling in infections so as to stop steroids. Let's say you have a patient of alcoholic hepatitis, you wish to give steroids in that patient. If there is a precise diagnosis of infection, you would like to not to give the steroids, because obviously infections when flared up in alcoholic hepatitis would lead to poor outcomes. Similar the case for AIH. And then there can be patients who are diagnosed with MDR infection. They can be through PCR and NGS. We could isolate them and cohort them for better management to prevent the horizontal spread of these infections from one person to another. So lastly, I would just like to say that in battle against infections with ADACLF, I think one size fits all approach is no longer an option, and it's the time for precision to guide the prescription. Thank you very much.
Thank you, Dr. Nipun, for walking us through that methodically explored topic. And I'm quite sure that you very beautifully set the stage for making people understand how precision medicine stands on the bedrock of such important work which takes years to come. And with this, we move on to our last speaker of the session, who is none other than Dr. Jasmohan Bajaj. He's professor of medicine at Department of Gastroenterology, Hepatology and Nutrition at Virginia Commonwealth University, US. And I think he's going to summarize the whole thing and the entire session by talking on microbiome-centered therapies in cirrhosis. Over to you, Dr. Bajaj.
Thank you. While I get this going, I would like to thank INASL for this wonderful invitation. And is it coming? Can you check? So thank you. So I'm going to focus more on microbiome-centered therapy only for infections. Of course, microbiome-centered therapy in cirrhosis has been used for many, many other conditions, such as hepatic encephalopathy, MASLD, etc. But I'm trying to tell you what, and I'll tell you right at the outset, the best microbiome-centered therapy you can do is not give unnecessary antibiotics. That's the number one takeaway. Okay. So what microbiome-centered therapies are there? How can they influence outcomes in cirrhosis? What is the impact of these therapies on infections and or the risk of infections? And what are the future directions? Because we are really already living in the future. Those things about community-acquired infections are gone, even in high-income countries, places where we have tight controls on antibiotics. So this was briefly mentioned by Dr. Verma. This is the cleared consortium, which you can see represents every continent that is populated across the world. And what we found, the infections 32%, and majority of them did have drug resistance. But majority of them were gram negative, followed by gram positive with a DRO rate of 22%. But as he also said, many of the low and middle countries actually did not have culture positivity because they did not have culture bottles or a microbiology department. So in the reverse way, this was worse because they were actually giving the broadest spectrum antibiotic and just letting the symptoms guide their clinical decisions because of want of something else. And because they're in low and middle income countries, the patients also come in much later because there is less outpatient contact with those patients. So regional perspectives are really important, also pointed out by Dr. Verma. Both Vermas, I realized. Okay, sorry, Verma and Verma. Okay, so the gut microbiome and host interactions is really important. It's not just what the microbiome is, but what it actually is doing. So there are some microbes that are particularly bad. If you look at SBP is usually a monomicrobial infection. And you can ask yourself, why is that? There are millions of different types of microbes. Why is that one E. coli able to snake its way through the mesentery and go through the mesenteric lymph nodes? It's because not only do you have to have a failure of immunity, you also have to have bad bugs that have that together. And unfortunately, in patients with cirrhosis, there's a failure of systemic and local immunity, in addition to the multiple things that we do to our patients. So antibiotic resistance genes, virulence factors, and cytolysine are all things that make a bug worse, that would make them much more likely to cause an infection that would have a bad outcome in these patients. So what are the microbiome central therapies? Of course, the easiest one is diet, prebiotics, fermented foods, and postbiotics. Of course, there are probiotics, FMT, live biotherapeutics such as defined consortia. And if we are exceptionally lucky, there could be one strain that actually mops out everything that is bad. But in chronic diseases such as cirrhosis, it's highly unlikely that a single strain in human studies is going to actually solve the problem, given the complexity. Of course, antibiotics that we use day in and day out, and phage therapy that we hope to at some point use. So probiotics, live microorganisms, prebiotics are something that are not live, but the good bacteria use them and become probiotics. And symbiotics are both. The important thing is postbiotics. This is the preparation of inanimate microorganisms or their components. So this is not short chain fatty acids. This is not their products. It's actually the dead microbes themselves that in some cases have the ability to elicit an immune reaction that might actually be beneficial. And fermented foods, of course, we know we are in the land of lassi right here. That is really important, but not all fermented foods actually have intact organisms in them. For example, if someone asks you that beer is fermented, let me drink beer for my cirrhosis, there is, apart from the alcohol content, there is no active microorganism in the beer at that same time. Whereas sauerkraut, lassi, any kind of yogurt actually has fermented foods and the live microorganisms in there. So it is important for us to realize the difference. So first thing you want to do, prevent gut colonization, prebiotics, dietary interventions, and selective digestive decontamination. Now, this is very different. You can't give people polymyxin, but something that we normally use a lot in our patients is rifaximin, which you think is a selective decontaminant. Does it work for infection prevention? No. I'm going to talk to you. I've already gave you a spoiler alert. FMT, then bacteriophage therapy, and bacterial consortium. And then this is how things go, from feces to FMT to purified feces to selected consortia and a single product. So this is, in a nutshell, the amount and breadth of microbiome-centered therapy that currently exists. So what about diet? In patients with cirrhosis, did diet have any impact on progression and or infections? So in this cohort of patients from Turkey and USA, we just did the microbiome analysis. And if you know, alpha diversity means the amount of different bugs that are in a particular sample. The higher the alpha diversity, you would assume that it's a more stronger, resilient microbiome. It's more like a rainforest and not like a desert. Okay. So what we found in compensated controls and decompensated patients, in Turkish patients, there was no difference at all. Whereas in American patients, it reduced as people went from controls to compensated to decompensated. So what happened? Did the Turkish people not know how to diagnose cirrhosis? That's not the case. They were drinking ayran every day, which is even a thicker, more fatty, more fermented milk product. And that was enough to actually change their diversity to the point that they became like the controls. And not only like that, they actually reduced their hospitalization, and their alpha diversity was one of the things that went into multivariable analysis. So in Brazilian diets, same thing. The Brazilian diet has more yogurt and more multigrain. They also had higher diversity and lower hospitalization. The reverse was found in the Mexican diet. Mexicans have a problem with lactose, and they also do, their diet is very carbohydrate rich and not very rich in protein. So they had the worst diet of all of them, worse than even an American diet. And that translated into a higher rate of hospitalizations. So this does not prove that a better diet will prevent hospitalizations. It just gives you an idea that if your patient is asking you for dietary advice, you may want to tell them to continue with the lassi, continue with the yogurt, and continue with the things that they would normally eat anyway in that patient. We are exceptionally lucky here that fermented milk products are part of our diet. So if we ask them to increase that while reducing the rest, it'll be a good thing. And this is a study that is under review right now. It's 7 cohorts from everywhere, and we did a lot of analysis of the diet and the microbiome, and yogurt did come out a little bit higher in this, but it's not approved, it's not published yet. So let's talk now about the next step. As we're going from the least complex to the more complex things, let's talk about prebiotics and probiotics. Lactulose is a prebiotic that we all use, but we use it in laxative quantities. So when you use lactulose, if you just use the Bristol stool scale instead of drowning the patient in lactulose so that they're dehydrated and do not want to see that again, you can actually potentially use this. It is bifidogenic. It increases the bifidobacteria. And in this study, which in at least in animal models, it reduces the VRE. Now, is this actually going to be translated in humans? Highly unlikely. But it tells you that it actually is a prebiotic when used in lower doses. And it increases the short chain fatty acids, which we all know are good. They nurture the epithelium. So lactulose in low doses without the laxative quantities could be potentially beneficial as a prebiotic. What about probiotics? Most of the studies, as I've said, were on hepatic encephalopathy. And in hepatic encephalopathy, it is effective based on some of the specific studies. But remember, all of these, the probiotic used was very different. So, for example, it's the equivalent of saying streptomycin and amikacin, put them all together, or streptomycin or daptomycin, put them all together in antibiotics. Are antibiotics good? You can't really plug them, but even with that, there was some hint. But this is an important thing. Lactobacillus, the one thing that makes it such a good probiotic, also makes it a very bad pathogen. So if you get lactobacillus bacteremia, your patient is kind of done for. This patient, cirrhosis is a risk factor for lactobacillus bacteremia. So do not overuse this just for its beneficial perspective. When you use it in diet, the diet kind of takes, you can only eat so much yogurt and then you get full. But when you give it in industrial quantities in that, there is a potential for this could also cause harm. So currently there is no evidence to support probiotics as a standalone therapy for infection prevention or treatment in cirrhosis. Remember, I'm focusing only on infection. So we focus a lot on novelty, what is new, but we need to focus on value, things we just talked about, the diet, etc. And also we suffer from what we call the shiny object syndrome. Ooh, what's next? What's next? But we need to consolidate what we have. And what we have is something that we do pretty horribly, as pretty much by Verma and Verma et al. Has told us that we have SBP prophylaxis and broad spectrum antibiotic overuse is really a problem. And what about rifaximin? We think it's a cure for everything. Okay, that is truly not the case. Let's talk about SBP prophylaxis. This is primary SBP prophylaxis, which is the first that the patient has not had SBP. So these are people who developed their first SBP episode on primary SBP prophylaxis, which means they failed this. And these are people who developed their first SBP episode not on primary prophylaxis, which means these could have been potential candidates. So they are much more likely to have resistant organisms, much more likely to have, fluoroquinolone and Bactrim resistant organisms. And this resulted in more liver transplant and more second SBP. And this is a large cohort of veterans across the United States. What about primary SBP prophylaxis in randomized control trials? In this study with norfloxacin, no effect on mortality. And this study done on rifaximin, done by the exact criteria that the AASLD and INASL propose, absolutely nothing. You can see these are almost on top of each other. Rifaximin was not effective, and primary prophylaxis right now is associated with more deaths than nothing. In the VA system across the US, it is kind of banned now. They say use it at will, but they do not, we are okay not starting this. In my practice, I do not start this. What about the more tense secondary SBP prophylaxis after they have had one episode? And this, in the veterans database, you can see secondary prophylaxis should actually be protective, right? This is recurrence. People with secondary prophylaxis actually had more recurrence, which was replicated in this as well. And not only for secondary SBP, it was also for UTIs. What is common between UTI and SBP? They're both caused by gram-negative rods. So this is something which you put fluoroquinolones in those patients. This is a big problem, big problem. So again, as I said, instead of going after the shiny new object, we have to re-evaluate what we are currently doing. And SBP prophylaxis is strictly in the crosshairs right now, especially primary. Non-absorbable antibiotics, we already just talked about rifaximin in that randomized control trial. And this is even a bigger randomized control trial in patients who had high MELD, who had to prevent ACLF, and simvastatin plus rifaximin versus placebo. Nothing, did not work, did not do anything. So again, for those who think that, okay, broad spectrum is not good, let's start rifaximin. It is useless. It is also expensive, and anything you put more in your patient's hands, it's more chance of polypharmacy and interaction. And it is expensive for patients. So why would you want to do something that is not useful? It is very good for hepatic encephalopathy. You should be using it for that, but not for these random things that would actually compromise the patient's microbiome. Again, shiny objects. Let's go to the shiny objects. Not really shiny, they're very brown. Let's talk about FMT, which is MDROs. As pretty much told by Dr. Verma, the FMTs do reduce multi-drug resistant organisms in non-cirrhosis populations. And as you can see, these are patients who got bone marrow transplant. Even in bone marrow transplant, FMT not only did not cause infection, it actually reduced the infection in these people. And not really infections, it reduced the MDRO culture. Whether that translated into lower infection or not is a different issue. What about in cirrhosis? All of these trials that have been done, there's only one trial that had protection from infections proved. And that is the alcohol-related hepatitis trial done in Delhi. And this 120 patients with the NG tube open label, but this was not the primary outcome. This was something that they found at the end of that study. At this stage, the FMT is not ready for prime for prevention of this. But what happens when you give FMT in those patients? What we found in this oral and the enema trial, that vancomycin and beta-lactamase ARGs reduced, and same thing with the antibiotic treatments, it reduced. But what was really scary and what brings it back to the SBP prophylaxis is quinolone resistance did not change with the FMT. So quinolone resistance was not quenched with the FMT as well in patients with cirrhosis. So it is again not a panacea. Instead of having to give people FMT, it's best to not give them antibiotics for unnecessary and prolonged indications so that you're not really left holding the bag. And again, FMT is not without its problems. It causes a lot of issues if you do not select the donor and if you do not select the patient population. What about phage therapy? What is difference between phages as well as bacteria? As antibiotics, phages are unique. They're very, very specific to an organism. They are also able to go through the biofilm, and that can actually go very deeply. But that means you have to figure out what that infection is coming from. So if you do not have a good culture, or the culture does not know, it has to be developed for that strain. And the pharmacodynamics and pharmacokinetics are very different. And bacteria also develop phage resistance. These are the trials for non-cirrhosis population, but you can see these are very, very specific trials that you have to do on specific things. So again, phage therapy is not really available right now. So what should we do now? The best microbiome-centered therapy you can do, less is more. Less unnecessary antibiotics and SBP prophylaxis. These are all double-edged swords. Broad spectrum antibiotics, broader spectrum antibiotics than required, longer duration than required. FMT, probiotics, rifaximin. Rifaximin did not prevent the first SBP and could also increase resistance. Probiotics, cirrhosis is a cause of lactobacillus bacteremia. So if you give them in the food, that's fine. Avoid focus on shiny new objects. Encourage whole grain and fermented milk products in diet. Focus on rapid infection diagnosis, as pointed out by Dr. Nipun Verma, and appropriate therapy, addressing etiologies, embracing stewardship as a culture. It's a change in culture. It is not something that you can do one or two. The entire culture of the ecosystem has to change. Newer therapies have an evolving role, but really are not ready for prime time. Thank you.
Thank you, Dr. Bajaj. Should I say it was icing on, or should I say reword it? It was a fermented yogurt on the cake. Thank you for that excellent talk. May I invite you to join for further discussion? We can have a couple of questions from the audience. May I have a shot at the discussion before anyone else jumps in with their questions? My question is to you, Dr. Bajaj. I am so, as an antimicrobial steward in the hospital, I'm so glad you brought out such important topics. I just wanted to ask you how difficult you find to convince people to stop misusing rifaximin. We see its use right from the emergency to the wards, subsequently to the hospitals. And I would like to share with you, nearly 60%, if not more, would be totally without any evidence.
So I'm fortunate to be in US where it's, these things are very tightly controlled, and rifaximin is also very expensive.
Okay.
So it is only used by insurance for that hepatic encephalopathy prevention if the patients have failed lactulose. But in conditions like this, your biggest strength is the lack of benefit. So these trials are incredibly important. This JAMA trial and this Journal of Hepatology trial, which showed negative results. And these are expensive things. They may not be as expensive as they are in the US, but it still adds up to the patient's bank balance. So my feeling is if you have some informatics made from these trials and give them across the country, across people, and put some educational sessions, I think that would help this a lot more. And you can tell the patients that this is actually harming you or is not helping you, because some patients are attached to their pills and they feel like they're doing nothing. But then from the provider perspective, this is the way I would go.
So yeah, I think we really need to innovate on our messaging there. With that, we can have a couple of questions from the audience. Yeah, do we have some of them?
So,
Yes.
can I mention
Yeah,
in
please.
context with rifaximin? So our center hepatologists are very keen to use for every patient, but we have very strict antimicrobial stewardship, and we put the local guideline and just say this is just for indicated hepatic encephalopathy. You should not be using anywhere else, and we strongly do not recommend STD selective decontamination in all these cirrhotic patients anymore. With our experience, it doesn't work.
Well, there is a study from India as well showing that there is no benefit of rifaximin in acute on chronic liver failure patients. So I have recently analyzed one of my cohort of around 170 patients, how rifaximin affects the MDR colonization. So the answer is it is the broad spectrum antimicrobial use over last 3 months which nullified its effect on the MDRO colonization. So I wish we should adjust those factors, and when we say that it affects or not affects the
It's so
colonization.
surprising. With despite all the evidence out there, there is such a selective blindness when it comes to actually executing what is the right practice. Yes, I'll not take your time away.
I'll repeat it. So you talked about long duration of antibiotic. What does that long duration means for a culture positive infection? What should be the ideal duration of antibiotic?
That depends on the patient's, the severity of the infection. That depends on what the causative organism is, and depends on your ID colleagues who are sitting right here. I tend to convert them to oral as quickly as possible so that the patient can get out of the hospital, and follow them. So there's no one size fits all for that. And the more sick the patient, the more likely you'll need a longer duration. And after that, so it's what I was trying to tell you is some people just put IV for a long time and put them on a PICC line, and then they have another source of infection right now, and they're in the hospital for longer. So if you can convert them into oral, send them out of the hospital to recover, if they're recovering better, that is better, and use the shortest possible duration. We have studies right now, not necessarily in cirrhosis, that instead of 14 days for bacteremia, you could actually do 7 days as well. I'm not sure that has been repeated in cirrhosis, but I wouldn't start just there yet because our patients are high risk. So I would continue to follow whatever the directions they were.
Yeah, thank
I
you.
think,
Yes.
sorry. We do monitor them very strictly for duration, and I think it varies according to the severity of how septic they are. And we have used biomarkers. In routinely basic biomarkers, you can use white cell counts, and if they have SPP, you can do the repeat SPP and how they are responding. Usually, in uncomplicated cases, we just go for 5 days. And in complicated cases with septic shock, it can end up maybe 2 weeks to 3 weeks.
Just put a clinical context. If patient of cirrhosis got intubated, we get a MDR Klebsiella from the ET tube. he recovered, he got extubated. Now, what should the duration?
So again, we do the biomarker. We do monitor with the procalcitonin. These MDR are colonized highly.
Just
They
to
will be
add,
colonized.
procalcitonin is not a good biomarker as suggested in
So-
pneumonia thing.
So we do the baseline. It is always high in the liver failure as well, acute on chronic, and we are actually doing analysis in these two group, acute on chronic liver failure and in cirrhotic patients. We do get very high biomarkers, and it is not a very good marker, but in some patient, if this showing response with antimicrobial decreasing, you know that this is responding.
Yes, and
And-
I think if I may just quickly add to what ma'am has just said, that we now have increasing evidence for shorter duration of therapy for even for these MDRO organisms. One clinical guides are also very good. I mean, constant improvement in oxygenation, for example, in the specific case that you talked about, or other parameters of severity. Say for us, for example, 3 days of stability in that state is a good enough guide for us to say we can stop. So, yeah, there are ways to make it shorter, but appropriate durations. Yes, sir.
I'm Rajiv Khanna from Pediatric Hepatology ILBS. So I have a question for Dr. Bajaj. You have done so many trials on FMTs which were mainly rectal based in comparison to the study from ILBS which was given through nasojejunal route. So when we looked up the methodology of doing FMT, and so how long the if the patient is already on antibiotics, so for how long the patient should be off antibiotics before considering, because that uniformity is not there in different studies. And also from the ILBS study, the patients are mostly sick, they are already receiving antibiotics, and also they are given FMT. So that actually also is not a uniformity between different studies.
Yeah. So the important question that you bring out is, we do my first trial. I was forced to give antibiotics because they were going after the IBD literature, where they had to do antibiotics to get rid of all the commensals, so they would be good. And I argued with them. These patients are already on rifaximin, and this is 2014 when I started that study. And at that stage, no one had done FMT in cirrhosis, and I was very scared because these people would get SBP, and then you would never know. So I said, okay, fine, we did it. But the trial that I showed later was the ARG analysis. In the pre-FMT, all the FMT did was quench the pre-FMT antibiotic associated resistance that happened in those. So right now in my practice, because I only do it in patients with cirrhosis who are on rifaximin, the rifaximin is the only antibiotic that is allowed, because to take that off in someone who needs it is really not really standard of care. In my other study that I didn't have time to go over, which is alcohol, in which some people have cirrhosis, they do not have any antibiotics on board. So I do not allow any antibiotics, even lactulose in my current study that is enrolling. So I use the most acceptable thing to the patient is a capsule. So we have the capsule, which is the important thing with that is you can also have placebo, and that will lend itself to a double-blind study. Now the ILBS adult study was very, very involved. 7 days of NG tube associated, and that's kind of untenable in a regular situation. All of our patients were outpatients, stable patients, and none of these were done for infection prevention. You have to remember that none of them were done for MDROs. Everything that we found was a kind of a offshoot or a secondary tertiary outcome or an MDRO gene reduction. So if you really want to do this, you actually have to have the MDRO resulting infection, not just the carriage, as the outcome of that. And of course, the first thing you need to do is to avoid all antibiotics, because then you'll be just creating, and you will be creating a fire and lighting it and trying to put it out at the same time.
But is there any comparison if
So our
in
last-
your patients, if
okay.
you have done rifaximin versus no rifaximin? Those
No, we
patients-
didn't, because
So-
we wanted to only do it in patients in whom there is no FDA approved alternative. So if someone fails lactulose, there is an FDA approved alternative that is covered by their insurance. Why would I give them with FMT, which may not have any proven benefit, where you have grade A evidence for rifaximin? So we would not, I personally as a doctor would not want to do that in those patients. So our third study that was published in JHEP this year, we compared in within similar groups of patients, whether oral or rectal or both, were better than placebo or each other. And it did not matter. As long as the patient got one FMT dose from oral, rectal, wherever, they were protected from HE recurrence than if they got a placebo. So ultimately, you have to do what is available for you. Reduce the antibiotics as much as possible because that FMT is a precious resource. You have to make sure enough of it goes into the patient to cause a functional change. I don't get very worried about whether there was engraftment or not. If the patient is protected from HE, that is my endpoint. I don't care how. I'm doing it right now. We're doing the analysis, but that's the really important. So if you have an endpoint, the endpoint should be clinical as much as possible.
So I see where the question regarding the, not for you, the Karan, the question regarding the overuse of antimicrobials is coming. Patients with ACLF are recommended by the INASL guidelines to be considered infected until proven otherwise, to start antimicrobials empirically. Is this the right approach? I would like to have the opinions of panel, and then I'd like to share mine.
Are you asking a question?
Yeah.
Okay. So ACLF, what, grade 3?
No, all ACLF.
No, ACLF 1 is basically, but they were dehydrated. Their, creatinine went up a little bit, and they were a little confused because of that. That I wouldn't call that ACLF. So that's why ACLF grade 3 or higher, yes. The important thing that we all forget is you have to draw the cultures before you do the antibiotics, and let the cultures guide the antibiotics. Rather than the reverse, let the antibiotic take its way and then try and figure out what happened to this patient. And that's where a lot of these things happen, especially if you're a tertiary quaternary center where these decisions have already been made somewhere else. And now the patient comes to you on a third generation cephalosporin with a gram-positive coverage as well. And now you don't know what to do with this patient. So I just call our ID colleagues. They really, really help us a lot. So thank you, both of you. I continue the antibiotics unless the patient is getting worse. And the patient is getting worse, we stop the antibiotic, we redraw cultures and make sure there's nothing else. We basically reculture the patient every time they hit our department, if they are not from us already. And our ER physicians are actually very good. They make sure that they do cultures before. And we've also for SBP, because people from India might find it very hard to believe, but it is extremely difficult in the US to get a TAP. You would think that is the easiest thing in the world, right? No. Only interventional radiology can do a TAP, or the ER people, but the ER is dealing with a million other things. So what they do, if a patient appears a little bit encephalopathic, they start him on antibiotics and then you're done. Okay. So what we ended up doing, we created a machine learning model with things that are available which actually excludes 80% of the people who will not have SBP, so that we've now put it in the ER. So they're actually only doing it in the 20% of people who cannot be safely excluded. So everything, and I sent it to review, and all the Europeans came, what, you can't do a TAP? I said, no, we can't. It's the richest country in the world, and they can't do a TAP because in our residency program, learning how to do a paracentesis is optional. Please do not ask me why, but it is optional. And suddenly, when they become attendings, they're supposed to know how to do this. How? No one taught them. So everyone defaults to, let's go to interventional radiology. Interventional radiology has a million other things to do. They have to put PIC lines. They have to put the portacats. They're not going to waste their time doing your diagnostic taps for you. So the default, even in the US, is to start broad spectrum antibiotics. It could be SBP. So that's why it is very local. Every challenge is very local. So you've got to figure out where your choke point is and try to solve this. Our choke point was random use of antibiotics because people could not be bothered to get a TAP in time. Yeah, that's what it is. Yeah, it's surprising and shocking.
Yes, Dr. Verma, you wanted to say
and we have a quite big population of acute or chronic liver failure, and most of them, I don't know whether you get them in the multi-organ failure and end up in the liver intensive care unit. So obviously, when they're very sick with a multi-organ failure, we do have to use a broad spectrum antimicrobial. Early diagnosis you will do, but the duration is again it's so variable. Sometimes you continue for very long time because the biomarkers which we routinely investigate, like white cell count, is one of the best routine marker you can easily do in the laboratory, and some of the labs can do procalcitonin, etc. But white cell count in these patients are always in 40,000, 50,000, and they stay persistently high. So you know where you decide what you want to do. So because I deal with them every day, because they rely on us. The better thing is that they rely on you for the decision of antimicrobial,
especially
which is the most
yeah.
difficult thing. I found it myself into their situation, that
No,
how we deal with that.
It's a clinical
It is a
factor.
difficult
Yeah,
thing.
it's a clinical factor. If the patient is improving, we assume the antibiotics are working and we let it continue their course while you do one set of cultures. If the patient is not improving, obviously those antibiotics are either not right or were never needed in the first place. So
So indeed, that remains the bottom line, and the final message would be have a plan for de-escalation, even if you have started. And if there are no more questions, I'll just have one question for Dr. Nipun, and that is regarding what do you plan with to do with your findings, and if you can just give a quick comment to that, I'd like to conclude the session after that.
So, well, if anybody we can, get an ELISA, which is just a 4 hours test, galectin 3 binding protein, I would like to ask each one of you to validate. This is something which we can use to rule out infection and actually prevent overuse of antimicrobials. And it is just not alone, it is with combination of procalcitonin. And there was an incremental improvement in discrimination when we used this with procal. So therefore, if it is validated, it can be a widespread marker for reducing the overuse of antimicrobials. Thank you.
Thank you so much. And with this, we conclude the session.
So with that, we come to an end of this wonderful session on infections and cirrhosis. May I request the chairperson and the speakers to kindly come on stage for a group photograph. We'll now disperse after that and shall meet again after the lunch. Can we have the speakers, please, on the stage?
It's a pleasure.
perfect person.
So many questions for each It was a pleasure listening to you. He keeps talking about everything.